Bieber, our wonderful ENT surgeon with the Northern Cochlear Implant Programme. Now, just before we get started with Bill, we have a couple of little things to let you know. We are captioning this for you this morning. So on the bottom of your screen on the right-hand side, you will see a little closed caption icon. If you click on that icon, you can choose to have subtitles or a transcript. The subtitles will show up along the bottom of the screen, and the transcript will show up on a panel on the side of your screen, which you will see the whole transcript. There is a couple of seconds delay in it. It's just a functionality of the Zoom in captioning. So I do apologize about the slight delay. But it is, as I said, it's just a functionality of the captioning for us. Now, if you have got questions today for Bill, we will be able to ask those at the end of the session. We have got quite a few of you joining us this morning, so we might not be able to get to all questions, but we will try our best. Questions will be in relation to the CI surgery here in New Zealand and, of course, the impact of COVID. That's what we'll be able to answer questions on. If there's any personal questions, I do apologise, we'll not be able to get to those today. So without further ado, I'm going to introduce Bill Bieber, who's been with us now doing surgery in New Zealand for 30 years now, Bill?
Yes, it is indeed. 34, in fact.
34. And in that time, Bill, how many CI surgeries have been done in New Zealand to date?
Well, I think between 15 and 1600, I'm not clear on the exact number, but the problem has been that we've had several years where, I mean, there was one year that we only did 5 the whole year.
Wow.
Because of funding problems. So it doesn't seem a large number over 30 odd years, but that's the reason it's been the funding limitations.
Right, okay. So with that, Bill, I mean, I think we'll take a step back. So really, can you start right from the beginning? What is the CI and what is the reality? What does it actually mean?
Well, yes, that's a good question, because really my definition of a cochlear implant is that it's a device which provides auditory sensations to severely or profoundly deaf individuals who in fact derive no significant benefit from the use of hearing aids or in fact of vibrotactile devices. But I think in reality, what people should do is consider it as a sophisticated type of hearing aid because it is helping your hearing. And they should also understand that when their CI is switched off, they are still profoundly deaf individuals. And of course, the other difference is that it involves surgery to put part of it into the ear. So it does differ in that respect as well.
So what would the indications be for someone with a severe to profound hearing loss, say, as for an adult and for a child, and for urgent cases? What would those be, Bill?
Well, we've got 3 main indications. In adults, it's severe to profound hearing loss in those adults who've had previous hearing experience. So if in fact they were missed as a child and never got hearing aids, and haven't developed any useful hearing, then a cochlear implant doesn't work in those people when they're adults. So
Right.
they need to have previous hearing experience, which is why we emphasize the importance of using hearing aids, even if patients don't feel they're doing very much good.
Yeah.
So that's the first indication. The second indication, of course, is congenitally deaf children. And there we want to pick them up as quickly as possible. And the thing I'd like to mention there is the newborn hearing screening program, which revolutionized the number of children that we were able to diagnose at an early stage. At one stage in New Zealand, the average age of diagnosis of severe congenital hearing loss was 3.5.
Oh, wow.
And we now regard that as far too late.
Yeah.
And then the third indication is progressive congenital hearing loss in children who have had previous hearing, were wearing hearing aids, but then the hearing aids became ineffective. In terms of urgency, diagnosing and getting cochlear implants into babies, so we'd like to do it from 6 months onwards, and meningitis is the other cause for indication for urgent insertion, because the meningitis can in fact close off the cochlear duct so that we can't actually get an implant in.
So this will be the same in adults as well, Bill, the same.
And that's the same in adults. So that becomes an urgent indication in adults as well as children.
And would there be any other instances in adults where it would be deemed urgent, Bill?
Well, I think sudden deafness in an only hearing ear. So if somebody, so people have only one hearing ear, totally reliant on it. So if they have a head injury or an infection or some other thing happens, then they've gone off the ear. They have no speech reading skills, and they are in a very desperate situation. So they go right to the top of the list.
Yeah. Yeah, because in New Zealand, of course, we've got the clinical list and the funding list, but I think we'll talk about that a little bit later.
Yes.
So following on from that, Bill, so what are the important considerations for CI? You sort of touched on a little bit there, but...
Yeah, so I've said early diagnosis, of course. Previous hearing experience is absolutely important. It's very important for potential recipients to have realistic expectations. It does not give normal hearing.
Right, yeah.
All people with hearing loss struggle in background noise, and that will be a common factor to everybody. Understanding the limitations of a cochlear implant, so it doesn't, as I say, give you normal hearing. How the family is working with the person. The family is extraordinarily important in learning to use the implant, both for children and adults. And access to learning to use it is critical as well. So if you're on your own, you don't do quite so well, really.
Yeah, because I suppose the technology now is getting really quite advanced, which I know we're going to talk about later as well, Bill, but it is being able to have the skills to learn that technology to maximize the outcomes with your cochlear implant. Yes,
well, it's practice with learning to listen. So a lot of people, even if they don't think they are lip reading, are. Yeah. So a lot of people with severe hearing loss don't like people walking away, don't like men with beards, because they are using that extra piece of information. Yeah. So in fact, one of the important parts of learning to use the implant is having a family member or a friend reading out articles and things with their lips covered, so that the client has to learn to listen.
Yeah. So on that, Bill, it's like those are important things, but what isn't important when you're considering a cochlear implant for a client? Because some people think that they're too old, for example, or, you know what I mean, and other factors. So what isn't actually important when you're considering a CI?
Absolutely. So what you've got to have is an inner ear that can be implanted. In other words, it hasn't been obliterated by meningitis or completely destroyed by a head injury or something like that. It's vital that you have a functioning hearing nerve, the cochlear nerve, which joins the actual inner ear to the hearing part of the brain, or to the base of the brain. Yeah. You need to have an auditory cortex. That means the hearing part of your brain needs to be functioning. And that really means you've got to have the cognitive ability to learn to use the implant.
Yeah, which I mean is really important, isn't it? You know what I mean? Because there is a lot involved in relearning and retraining the brain, isn't there, to be able to listen and understand the sound.
Absolutely.
Sounds,
so in fact, age isn't a barrier, provided cognition is acceptable. So that includes starting off with a 6-month-old baby, but also with an older person. So in Australia, I know one patient who was 100 years old when he was implanted, but his brain was, so age is not really a barrier. The other factor is that the surgery generally is pretty well tolerated. Ear surgery isn't as invasive as big chest or tummy surgery. Yeah. So generally, I used to tell when I was doing babies, the mothers of the babies, that it was safer and less painful for their baby to have a cochlear implant than to have its tonsils out.
Wow.
Yeah. So, and everybody thinks tonsillectomy is an easy, simple operation.
Yeah, yeah.
And then the other factor that sometimes is quite important is that even if a child has multiple handicaps, it's not a contraindication to getting a CI. And in fact, it often helps manage the other handicaps.
Yeah, that's really quite interesting to know, because you would have thought differently, really, wouldn't you?
Yeah, but provided they have the ability to learn and get some benefit from the implant, then it often helps manage the whole child's dynamics.
So Bill, I'm going to put it onto a slideshow now to show you your slides, because you've got one coming up here on where you talk about the physiological hearing and how SCI actually works. So I'm going to put the screen share, and hopefully people can see the slides and still be able to, you know, hear you over the slides. So we'll just slide share this for you a little bit and see how we'll go.
Yeah.
So I'm just going to put it up here, and hopefully you can see. So we'll go into this slide here.
Yeah.
So we'll go from current slide. So Bill will talk to this. Yeah.
And so the reason I put these two slides in, because it still amazes me how wonderful the brain is. So hearing, normal hearing is, you can see the three little bones of hearing and the stirrup bone. That moves, vibrates with sound, and that sends a traveling fluid wave, which then stimulates what's called the scalar media, where the actual hair cells are. And the traveling wave picks up the different frequencies, and that then converts that traveling wave into energy going down the cochlear nerve, which you can see up at the top right part of the diagram. And so that's a traveling wave stimulating the hair cells. And of course, in people with profound or severe profound hearing loss, they have very few hearing cells left. Yeah. And it's the ones at the start where the stirrup bones are. Those are the high frequency cells. Those are the ones that die first.
Right.
So if we move on to the next slide, yeah. This is an old one from Cochlear, the original, almost the original slide. And you can see the electrode array has been pushed through what's called the scalar vestibule, but it's not in the inner ear itself. The inner ear is that little triangle at the edge of the two big circles. And this one's an old slide. It's on the outside edge. The modern electrode hugs where the nerve is going up in the center. And of course, what it's doing is directly stimulating the nerve. So it's completely unphysiological from the normal hearing point of view, but stimulating the nerve is enough to make the hearing brain listen to the sounds. So it's amazing.
So hold on. So that you're going to talk us through the hardware and the software, Bill?
Yeah, so there's two bits of the implant. There's the implantable bit, which is on the top slide. It's the bit on the left, and you can see two electrodes. One is the one that fits in the cochlear duct, and the other is a ground electrode. And then on the right of the top slide is the external hardware with the antenna, which is the round thing looking like a steering wheel, and that sits on the magnet, and then the other part hangs behind the ear like an ordinary hearing aid. And then in the bottom part of the slide, you can see it's tucked behind the ear. The wire goes through into the inner ear, which is that snail shell bit on the right-hand side. And this slide is so old that the box next to the ear is the old speech processor. And of course, that's now been miniaturized to go into behind the ear. But in the old days, they used to wear it on their belt. And babies still do when their ears are too small to
of course,
hold the speech processor.
All right, so I think, is there any more slides you want to talk through at the minute?
Yeah, just the next slide.
Oh, yes, yeah.
Just to show us that you can see the way it works. The sound is received by the microphone in the external part of the hearing aid, of this cochlear implant. It's sent to the speech processor, which is now in the bit behind the ear, used to be in that box.
Yeah.
Speech processor breaks it into codes. The codes are then transmitted up to the cochlear implant and through the skin into the antenna of the actual implanted device. That then recodes it back into electrical stimuli, which then stimulates the nerve, which sends those sounds up to the auditory cortex. No, so that's why you still have to have a nerve, and that's why you still have to have a hearing brain.
Yeah, and as you said, really important why you have to wear the hearing aid, even though you think you're not getting any benefit from it while you're waiting for your CI.
Yes, and of course, actually, what you're hearing is this coded sound. It's not natural sound.
Mm-hmm. Right,
But
so
the brain is so amazing, it just converts it.
it's amazing. The
Yep.
technology is just phenomenal. So stop the share and bring you back, Bill.
Okay.
So yeah, um, so we're going to talk about the CI software. So you talked about the hardware. So there's a difference between the CI hardware and the CI software. So do you want to talk us a little bit about the software, Bill, and the advances that have happened over the years with the software?
Well, the thing about the software, where there has been many upgrades over the years, and the main effect of that has been the speed at which people learn to use their implant. So when we first started doing it, we used to warn people that would take months for them to get used to it, and it'd be slow progress, and that it would be hard work. Well, now the speed at which most people learn to use it is extraordinary. And of course, the sounds are better. There's better reception with music. So all those things that people want with their hearing are built into the new software. But what is also vital is that most of the new software can be used on the old implants. There's a little bit of redundancy,
Yeah.
but people don't have to have their old implant taken out and a new one put in just to deal with the new software.
That's phenomenal.
That's a very important point that people like to understand.
Yeah, because sometimes they think they'll have to get it exchanged at some point, but it should last them over their lifetime, the internal part of the CI, yeah.
That's the theory, yes, absolutely.
So, Bill, if somebody, we often find out about people that are being referred into the program, and sometimes people haven't been informed, or they get informed really late because the thing's a bit of confusion about who's suitable and when we should send them through for assessment. So, can you walk us through sort of the assessment and referral process, and when ideally you would like to see someone being referred into the program for a CI?
Well, the simple answer to that question is we want everybody to be referred. And there are two main reasons. The first is that a lot of health professionals don't seem to think about it, and often patients will minimize the effect of their hearing loss. And the second is, of course, that everybody knows that there's a bit of a funding problem. And so they think, oh, well, I'll never get accepted, so why would I apply in the first place?
Yeah.
But of course, we actually want people to be referred and to be assessed. And then I'll go through the process a little bit later. But basically, once you're referred to the program, you go through a series of audiological workup. You have to see one of the ENT surgeons to make sure that the anatomy is right and that the pathology is suitable. And also you see a habilitationist to learn about what you might have to go through to learn to use an implant. But it's done on a prioritization score, as in fact all operations in New Zealand are now. And there are really 9 points in the prioritization score. So for each little factor, and some of it is loneliness, it's work, it's family, it's danger of isolation, it's people living by themselves with no warning of intruders or things like that. And the psychological effect of the hearing loss, they're all factors that add up to a total score. And if in the end, the audiologists feel that the cochlear implant will do better than the hearing aid setup maximized for that patient, but as good as possible, that the cochlear implant will be better, then we put them on the waiting list.
Right, and then with the waiting list, so that would be the clinical waiting list, and then they would go on to the funding waiting list. Is that correct, Bill, in New Zealand?
Yes, so the funding waiting list is really the people with the highest number of points are more likely to get the implant. And that's a living list. That's not what we don't like patients to understand is once you're on your list, you're there and you're there forever. In fact, of course, hearing deteriorates, people get older, health declines, and so the effect of the hearing loss changes. So in the Northern program, every 2 years, we like to reassess those patients on the waiting list and readjust their prioritization score.
Yeah,
And often the score will be made higher, so they go further up the list, because the problem is with limited numbers of limited funding, that every so often an urgent patient will come through and go to the top of the list.
Yeah.
And therefore, you know, if somebody who's nearly there gets pushed down again.
Yeah, so it's not a static list, is it? Where it's like you roll.
Oh, it's absolutely not a static list. Yeah.
Yeah, it's fluid, so it changes.
Yes. Yeah. But that's why we like to reassess, and we like to make sure that people on the list understand if there's circumstances or their hearing changes, we want to know.
And that's all part of the multidisciplinary team working together, isn't it, Bill? Everybody
Absolutely.
Decisions not made in a silo by the surgeon or the audiologist. It's the multidisciplinary team that comes together. And
the audiology and habilitationists are a hugely important part of the whole teamwork. No, we are definitely a team.
Yeah, yeah. So do you want to talk through then the role the audiologist plays, and then the surgeon and the habilitationist in the program, Bill? Do you just want to outline that a little bit?
Yeah, so the audiologists will obviously test your hearing and look at your hearing aid setup, and if it's not adequate, then either suggest the patient's own audiologist adjusts it, or new hearing aids would be advisable. So it's quite interesting. A fair number of patients referred to the program, in fact, once their hearing aid setup has been looked at and adjusted, they actually do much better and don't need to go onto the program.
Oh, wow.
So yes, so they then cope better, because there's no point in doing an implant, expensive, an operation, if you're not going to do better than your hearing aid setup.
Yeah.
So they also look for what's called auditory neuropathy, which is where the hearing seems okay, but the response to hearing is very poor.
Yeah.
And what they also do is describe what happens with switch on and mapping, how the implant actually works.
Oh, that's fantastic. And then the surgeon does.
So the surgeon is there to try and find out why the patient has lost their hearing, any associated medical conditions. They need to get a CT scan done to make sure the anatomy of the inner ear is suitable for receiving an implant. Sometimes an MRI scan to make sure that the auditory nerve and the auditory cortex are in good condition. And they will, of course, describe the operation. And part of that is deciding which ear. If you've got two bad ears, sometimes, of course, there's only one ear that can be implanted, so that's easy.
Yeah.
But if you've got two ears, you then have to work out which is going to be the better ear, and that's based on the anatomy, the amount of function, the degree of hearing loss, the amount of usage. So one ear sometimes has had hearing aid for much longer than the other ear. And those are all factors in how you decide which ear to operate on.
Because things have changed a little bit, haven't they, Bill, over the years, where, you know, if you had residual in one ear, you would have left it, but now you can preserve some residual hearing with the new implants that you're using. Is that correct?
Absolutely, yes. So we set out to try and preserve hearing. It's still a little bit haphazard. There's quite a bit of work to be done on that yet, but there are many instances where we can preserve hearing, and I'll talk about that a little bit later in new and what's going to happen in the future.
Yeah, yeah. So we've gone through, you know, the role of everybody and why we need the scanning and to make sure the ear is physiologically perfect for, you know, getting an implant. So the other thing you've covered in here, Bill, is the psychological assessment. So why would somebody need a psychological assessment for an implant? What would come into factor in there?
Well, just before we go into that, we did leave out one group of very important people called habilitationists, and those are the people who work on the clients learning to use their implant. So the audiologists set it up and help with learning to use, but the habilitationists prescribe the exercises, check out what's happening, troubleshoot problems, a vital part of the team.
So can you just, for people to understand, I mean, most people will understand, what's the difference between a habilitationist and a rehabilitationist?
A rehabilitationist is getting something going again. So you broke your leg, you start walking, you get rehabilitationists. Really, the hearing has been gone a long time, so you're learning to use a new type of hearing. So really, they're the same, but you would argue that the cochlear implant hearing is a new type of hearing. It's not the old hearing.
So would habilitations, would be fair to say, would be children, and then rehabilitation is more likely adults who've had hearing, but it has gone over time. That
Yeah.
Yeah.
Yes.
Yeah. Right. Yeah.
Basically, what they're doing is teaching you to use the implant and
Yeah.
encouraging you and supporting you.
Well, that's fantastic. And it's all of those roles are very important to get the whole outcome that we're looking for somebody with a CI. So they're all playing an exceptionally important together. Yeah. So
and then the psychological assessment is, we found, very helpful, because hearing loss causes isolation, causes loss of self-confidence, loss of self-worth, depression, anxiety, and that can greatly affect how people's lives. So it's an important part of the assessment, as well as sometimes ongoing problems after the implant is switched on, if it's not doing quite as well as the patient hoped.
Yeah.
So the patient does have to understand that we still can't 100% predict the success of the implant. So if a patient is unrealistic in what they want from it, then we get a little bit anxious about that.
Yeah, and I think for some people, I suppose we're all guilty of this as humans. We start to compare ourselves with somebody else. So if you know somebody else that's had an implant and they responded really quite well and quite quickly and regained their hearing, and then you're taking a little bit longer, those can be sort of struggles, that internal struggles that people can face, patients can face.
Absolutely. So the two phrases I tend to use with patients is, the first, it's not a race, and the second, it's not a competition.
Yeah.
So everybody is different.
Yeah. Yeah. It's the turtle in the hare. It's like, but your outcome hopefully will be better than you were at point A. When you get to point B, your outcome will, yeah.
The only thing we want from patients is for them to say, I love my implant, I have it switched on all day. To us, that is the basic line of success.
Yeah, not that we have taken it off and put it in your drawer.
Not that you've taken it off and put it on your drawer. It's the thing I go on about patients with hearing aids all the time.
Yeah.
No, that's failure on our part.
Yeah, yeah, because you really want them to be tuned in and listening, and yeah.
The whole point of it is communication with other people.
All right. So it's like, you've got some final steps here, Bill. Have you sort of gone over those? Have you any other sort of little highlights that you want to say in the final steps after the assessments have gone through?
No, I think that's covered a fair range, don't you?
Yeah, no, I think we've covered that really well, Bill. Thank you. So then when it comes to the selection of the device, so how does a surgeon decide which device is the best for the client? What factors are you considering?
Well, actually, just before we go back from that, so the last thing that happens before going on to that prioritization list is we hold an adult cochlear implant meeting, and there's a children's cochlear implant meeting as well, where everybody, the people involved with the assessment, meet, and we talk about each patient and the priority scores, and we mix and match. And so, and the family, and particularly with children, the family are involved in that discussion as to the suitability for receiving an implant.
Yeah.
So that's the meeting we have when they go onto the waiting list.
Right.
Yeah. So then the selection of the device, well, it depends a little bit on anatomy, pathology, and surgeon preference.
Yeah.
But if we're wanting to save hearing, there's a slimline. We call it slimline. So it's a
this slide, Bill, that you want me to show? Do you want me to show?
Yeah.
Right. So hold on. We'll just I just, there we go. Is it showing? Sorry. I'll just go on to
slide 27.
Sorry, there we go. Here we are. Bear with me. Hopefully we'll get it up now.
Well, back a bit, back a couple, back one.
Back one. Yep, there we go.
Oh, next one along.
This one.
Oh, I must have an extra slide. Sorry, so now go back to the 512. Back to the next slide. So we have the 512, which was the workhorse. It's been replaced by the 532. And if you move on to the next slide, Nick, yeah, and you can see in that one, you can see the curl of the electrode, and then there's a little brown part, that's the sheath. And what we do, so it arrives packaged like that, so that we know that the electrode array has got the memory of the cochlear curve.
Yeah.
And just before we put it into the ear, we pull that, what looks like an arrow, we pull that back, and that pulls the electrode into the stent or shaft, and that straightens it out. Then we place that whole stent into the inner ear, the first part of it, and then we reinsert the electrode array, which curls around what's called the modiolus, which is where the nerve is, and then we withdraw that sheath. So that's the latest device.
Yeah.
And the next one that's come, you can see at the top of the cochlear implant, there's that round thing. That's where the magnet is, and that was the problem with the old one, that we couldn't get MRI scans done.
Yeah.
So now the 632 is MRI compatible.
That's fantastic.
So that's a huge advance. Now, what I would like to talk about a little bit is we use Cochlear as our device provider. They come from Australia, so we have a very close association with them. And sometimes we're asked, well, why don't you use some of the other devices that are available? And there are really two main firms, one in America and one in Europe. And the reasons we stick with Cochlear is that the three types of devices are all really very similar in their capabilities, and each one does have a little bit of research and jumps ahead in a little step, and then the other two catch up, and another one will have a new little bit, but they're all remaining about equal in how they restore hearing. And the problem in New Zealand was we've got a small population, limited funding. If we had lots of different devices, there's a lot of extra equipment involved. It's America and Europe, a long way away. So we felt that sticking with Cochlear, who've been very good to the program, just meant we had a device we were familiar with and able to use easily. Now, having said all that, if a patient arrived from overseas with a different device, or there is some overwhelming indication to use one of the other types of devices, then we can go ahead and use them. We're not absolutely beholden to Cochlear.
Yeah, yeah. So there is options there if it's not suitable. Yeah.
But the reason for really staying with Cochlear is, it of course is an excellent device that's the most widely used one around the world, and we have a wonderful relationship with Cochlear.
Which is good to have that reassurance, isn't it, really, when you're implanting, and, you know, you've got a good, reliable device, and you've got the good, you know, support from the company as well for
Absolutely, yeah, yes, exactly.
Which is really good. So, but do you just want to talk us through, you know, a surgery, you know, so how long, you know, is a surgery, you know, the process involved itself?
Well, yeah, so you come in on the day of the operation, we check you in and sort it out, and one of the important things is marking the ear to make sure that we've got the correct ear, which is often a joke. If it's the left ear, are we sure it's the right one? It's, you know, it's a little joke we have. But you're not allowed into theatre without an arrow or some sort of mark on the side that's to be operated on. We shave a little bit of hair off, but really not too much. And then the operation itself takes 2 or 3 hours, but again, it's not a race. We're there to make sure it's done. So when people ask how long is it, I say until we've finished. And during the operation, if we're using that new device that I was showing, we actually get an X-ray done during the operation to confirm that the electrode array is in position and not twisted. And in fact, the great thing about that device I forgot to mention is that if something's not quite right, we can actually withdraw it, reload it, and start again. So up till then, with the old ones, if something wasn't quite right, we'd have to get a whole new implant out.
Yeah.
So that's been quite a little advance as well. Anyway, we confirm that the electrode is fine. And then as we're sewing up, we actually do what's called Nrt testing. And that's in, testing the integrity of the electrode array and setting thresholds. So that's made a huge difference, particularly in children when at switch on, because we can use those levels. But also in adults, we know the electrode is working well. And then we sew up and the patient goes back to recovery. And the point I always make then is when they first going to get out of bed, they need to have somebody there because ear surgery can make people a little bit off balance and dizzy.
Yeah.
So it's really important to just have somebody there the first time you go to get out of bed.
Yeah, we filmed one of your surgeries, didn't we, Bill, recently? So we will be sending out a link to everybody if they do want to actually watch, you know, a surgery and you talk us through the surgery, which is really quite informative and educational. So we will be sending that link out, as it's really good too. I found it really quite fascinating to watch, and it was really quite insightful. So it was, So for those,
well, that's why we love doing it, because basically the ear is healthy, so we're not dealing with infection and discharge and all sorts of horrible things. You've got a nice healthy ear. Generally the anatomy is good. You're putting something in that's going to, is going to make a fantastic difference to somebody's life. And so the implant surgery really is extremely enjoyable, which is why I'm still doing it.
Yeah, which it's you're a stalwart, Bill. As you said, it's life changing, and to see clients from before and after, it's something to behold, really, isn't it? You know, the difference in people.
Anyway, the thing is that you're only generally 1 night in hospital. It's not particularly painful. So although we do prescribe pain relief, I advise patients only to take it, get a good night's sleep, make sure, things like that. And then, of course, the other change is that we go to switch on the next day.
Yeah.
So patients, particularly for out-of-towners, that's a marvellous step forwards. So you discharge from the hospital, you go straight over to Hearing House and get switched on, and it works. It's quite. We used to wait 2 or 3 weeks for all the swelling to go down, but in fact, all that happens is the patient can wear the implant on the other ear, so it's not over the incision.
Yeah, of course.
But they get a week's extra hearing and knowledge, and that's actually particularly important for patients where this is the only hearing ear. So the scary thing about operating on an only hearing ear from the patient's point of view is, will it work? What will happen if it doesn't work? So if straight away they start to hear sounds, that whole confidence thing about the operation and the implant can be allayed and made easier.
Yeah, because I think many people used to get quite, anxious, didn't they, before their switch on, when they had to wait those 3 weeks not knowing, in complete silence. It was quite hard for them, wasn't it?
Absolutely, yes. Yeah, very frightening.
So what's the follow-up then, Bill? So after they've switched on and they go home, so they have rehabilitationists and things, and
then they have a program. So come back a week later for remapping. So there's 22 electrodes there, and things change as the electrode settles down and the fluids come back and the nerve settles down. The whole operation changes. So the map changes, and that's quite intensive to start with. And then the mapping sessions get delayed further and further. So the first 2 or 3 weeks, there's 3 mapping sessions,
Yeah.
and then it becomes a month, then 3 months, then 6 months, then once a year.
Wow. Wow, that's and in between that time, they've been given homework clearly by the rehabilitationists of listening exercises and things.
Absolutely, and where the family needs, family or friends or whoever come in to make them learn to listen. And they get new, and even after 3 or 4 months, they still have new experiences, new sounds. I see them 6 months afterwards, and they're still saying, "Oh, I heard this the other day, and I've not heard that for such a long time," or "I was in a group of people and I could hear what everybody was saying," and all those exciting things.
It's quite amazing, isn't it? And some people also say about the fatigue, because the brain's having to work really hard just after switch on, isn't it? So some people get really quite tired in those initial stages, don't they?
Absolutely. So that was one of the points that I have in the post-operative period, because the surgery isn't all that invasive. People want to get back to work. But in fact, the mental effort involved in learning to recognize and use the new sounds is huge. And don't rush back to work. Enjoy the new sounds, practice with them, get used to them so you're not exhausted at the end of the day.
Now, Bill, in slide 31, do you want me to put that up? You've got a slide there of an audiogram and then someone hearing preservation. Do you want me to put those up, or are you quite happy just to go on through, or would you like me to?
So the slide 30, it's not a very good slide, unfortunately, but if you can put it on, it just shows the degree of hearing loss that can be achieved.
Right, so hold on, I'll just, so it's this one.
That one there, yeah.
Yeah.
So the audiogram on the left-hand side, that's the hearing level, and those little circles at the bottom, that's really just a tiny little island of hearing. And the hearing aid can do a few low frequencies, but there's absolutely no high frequencies, which you can see in the top of the screen. The frequencies go from 125 to 8,000. And then you can see the hearing result from CI. It gets up to a hearing loss of about 35 decibels if we averaged it over those frequencies. So it's not normal hearing, which is between 0 and 20, but it's very close to it. And it's all those high frequencies. That's what makes the difference. That's the sibilance. So you can follow conversations and voices. After a while, voices sound normal.
Yeah, and I think what some people as well, they struggle with music, but I suppose that the cochlear implant was originally designed for people to get access to conversation and voice again. And I suppose the music, appreciating music can still be quite a challenge, or is that improving, Bill?
It is improving, but there's still quite a long way to go. And most people find that, of course, the tunes that they know, the songs that they know, they can recognize, but if you try new songs, it becomes a little bit more difficult. But some people do enjoy music, and that's part of their enjoyment of the cochlear implant. But that's quite a variable factor.
Yeah. It's an individualistic thing, isn't it? It's different for
Yes.
everybody really on that one. But I think when people are considering, well, I suppose funding from a government's level, they often talk about the cost per QALY. And so what that actually means when they look at cost benefit analysis, of implanting, choosing to do an implant or not. So what does that actually mean when we're health funders are looking at a cost per QALY, and where does a cochlear implant fit into that?
Yes, that's a good question, because QALY is quality of life.
Right.
And so they have a formula where if the intervention gets below a certain figure, which is about 30,000 US American dollars, then it's considered cost effective. And the way it works is the cost of the intervention versus the length of time the patient is going to get an advantage. So the most cost-effective intervention is neonatal intensive care. So if the baby survives, they've got the whole of the rest of the 70, 80, however many years it is, of normal life. And in fact, cochlear implant surgery is the fourth most cost-effective intervention there is, which is why it's so successful, because for a relatively small amount of money and not a whole lot of ongoing cost of drugs and that implant that other types of implants need, you have a few audiological expenses and there's a bit of upgrading every so often. But in fact, of course, the implant will last the rest of the person's life. So it's a very cost-effective, high-tech intervention. And that's why governments love it.
Yeah, we just need them to love it even more.
Yes, exactly. We've still got to work on that.
Yeah, well, it's a work in progress, isn't it, Bill? So it's yeah.
Yeah, so if you wanted to just go back to the one slide beforehand, that was a slide of showing that hearing can be preserved.
Hold on, Bill, I'll just bring it up now. I'll just go back on the screen share. Sorry, just bear with me. Here we go.
So the next slide,
This
that one there. So people might be able to see in the left-hand side, the right-hand side, which is actually the left ear, that there's a straight line along there. One's black, the other's red. And the red line is the hearing after insertion of the implant, but not what the patient's hearing through the implant. That's hearing through natural means. So the hearing has largely been preserved. And that's just an example of, so that patient might in the future benefit from what's called a hybrid aid. And we'll talk about that a little bit later. So that's just to show that hearing can be preserved. And it's we try to do it with everybody, because the more you do it, the better you get at it. So it's gentle technique, avoiding suction. We put a special steroid into the ear to try and get absorbed, which protects the inner ear. There's a whole lot of little things that we can do to try and save the hearing.
And Bill, you mentioned also in the next slide, you're talking about, the benefits of bilateral implants. So I know we are implanting children bilaterally, but we're not quite doing that for adults. So can you just walk us through the benefits of bilateral as opposed to unilateral?
Yes. When patients ask me why do they need two hearing aids, one of my answers is that God didn't give you two ears just to hang your spectacles on. That hearing with two ears gives you directionality. It is a definite advantage when there's background noise. And of course, that's the two things that people with a cochlear implant struggle in, that everything seems to come from the side of the implant. And they still have problems, as every hearing loss person does, in background noise. So the second implant, it's interesting, when you put the first implant in, there's a huge change in hearing.
Right, yeah.
If you do the second ear, the difference is not nearly as great because the patient's already got very useful hearing, but the quality of the hearing is greater, and the ability to hear in crowds and that localization of sound. So it's more normal.
Yeah. So I think it's because I know some clients have, especially clients that have that are in a working life. They might have had one publicly funded and then a privately funded the second one, and I've noticed a huge difference, especially if they're working. Like one of our clients is a nurse, and she's found it exceptionally beneficial. To have two as opposed to just one.
Absolutely, because in fact, if she's working in theatre, surgeons are wearing a mask. Everybody's wearing a mask, and you can't lip read.
That was actually one of them's working with the COVID situation at the minute, and she's had to say for people to stand back and pull their mask down because she can't say.
Yes.
Yeah, so it's needing to still see their mouth because it's really quite difficult.
Yes. So in an ideal world, we would be doing bilateral implants in adults. Obviously, in children, it's made a huge difference to their education. And it's totally wonderful that the government has been able to fund all children that need implants and bilaterally.
Yeah.
And sometimes we do both implants at once, and sometimes we do it sequentially depending on what the problem is and the pathology is. But adults, I mean, even if you wait 10 years, they can still make use of the implant in the second ear.
Wow.
So although ideally you would do it close to the first implant,
Yeah.
you can still make use of it at a much later date.
A later date. So Bill, the next thing you sort of had listed down here in your presentation, and just to let everybody know, Bill's presentation will be made available to you all. You're talking about hybrids, Bill. So what is, can you expand on what a hybrid?
Well, a hybrid is an implant that's got a hearing aid built into it.
Right.
So you have the implant at the back and you have the hearing aid in the ear canal or in part of the speech processor. And that gives you both the high frequency sound from the implant and the low frequency sound from the hearing aid, which is a great advantage, for example, in music.
Right.
Obviously, you have to save the hearing. It doesn't work in somebody who's lost all their hearing. So preservation of hearing and having a reasonable degree of hearing loss is essential as well. I mean, a reasonable degree of hearing still present. So
Yeah.
if you've got that audiogram I showed with that tiny little island, a hybrid would be a waste of time on that.
Right, right, right.
But so you have to have reasonable hearing loss, which in New Zealand, of course, the degree of hearing loss you need to get funded means that the hybrid's not very practical here.
Yeah, because you have to be really bad even to get the CI. So yeah, you're not going to sort of the middle range there. So what's the future innovations, Bill, do you see happening? It's is that where?
So I think what's going to happen, well, the problems, first of all, what are the problems?
Yeah.
And I mentioned earlier that it's still a little bit difficult to predict exactly what the outcome is.
Yeah.
And I've had one or two patients who didn't do as well as I would have expected, despite the fact that they were young and very keen and worked really hard, but still didn't really do quite as well. So we're not quite sure about that. So there's quite a lot of work to be done there. Improving hearing and noise is a common goal for both hearing aid manufacturers and cochlear implant manufacturers. And the chip that solves that problem is going to be very, very popular. So that bilateral. Pardon?
How far away is that, do you think?
I understand it's actually it's not that far away, so I think that's going to be a step quite soon.
Wow.
Sound localization with bilaterality is we know about that, but getting bilateral implants is important. And learning to listen to music, improving the listening to music, the complex sounds of a symphony, for example, and really improving that effort of listening so that patients aren't so exhausted with their hearing loss.
Yeah.
That makes a big difference. And then the other big problem in New Zealand is the funding.
Yeah, which is still ongoing, and it's, you know, hopefully we'll just, you know, continue to advocate really well and raise awareness of the issue and keep increasing that funding, because it is so vital, because more and more people are being referred through, and that's why we need people to be referred through to the program as well, because it's then reflecting the actual true need that's out there, isn't it, Bill?
Exactly. Though that's a very important part of understanding the degree of hearing loss and the extent in the general population.
Yeah, so what do you see for CI in 2020? So of course now we've been hit by COVID, Bill. So I mean, this has sort of thrown us off a little bit in 2020 in relation to CI in New Zealand. So can you sort of walk us through what the impact COVID has had, you know, on surgery and the considerations for recommencement and risks for people who have had a CI in relation to COVID? So
yeah. So in fact, the COVID, of course, has stopped all elective surgery at the moment. So we're not doing any cochlear implants during level 4, and it must be understood that mastoid or ear surgery is in fact one of the more risky types of surgery, because aerosols can come up from the eustachian tube in the back of the nose into the ear. So mastoid surgery is considered one of the risky surgeries, but it's a healthy ear, and it's becoming apparent that elective surgery will start again quite soon, and provided proper precautions have been taken, I think that we'll be back doing cochlear implant surgery reasonably quickly. And I've spoken with the authorities, and it's certainly not going to be months, it's going to be weeks.
And is there capacity there to work through the backlog of those that had to have their surgery postponed and those that are due to have surgery? Will there be,
I think there'll be
to
capacity to do that, because the hearing loss is considered an important part of a patient's disabilities. And the other thing is that covoid, if you get an implant, you're no more at risk or less at risk of getting covoid. So the implant itself won't affect the viral infection.
Right. Well, that's good to know, because people are always a bit concerned, are they more at risk of, contracting it because they've got a CI or another medical issue, so it's good to know.
So because everybody wants a vaccine for covoid, I should mention that we do like patients who've received a cochlear implant to go through a vaccination schedule, particularly to avoid the risk of meningitis. So I did have a slide, it's a complex slide, but the important thing is that when a patient is accepted onto the list for receiving a cochlear implant, their general practitioner is actually sent a note explaining the need for a vaccination program.
Oh, that's really good, Bill. It's I know even myself this year I had the flu and the pneumonia vaccination, so I took a double whammy. So it's they are available for people who have got health issues and take advantage of them. It might not protect you.
And the government will pay for your vaccination. If you're a cochlear implant patient, the government will pay for you.
Yeah, for those. So, and it's just something to protect you over winter anyhow and keep you well and healthy. It's not against COVID, just keep you well and healthy.
Yeah.
And so Bill, did you have anything else that you wanted to add? So where you see the future in the next 20 years, to see if a slide down there about the next 20 years, or have I missed something else out?
Well, I've got a little list there, and the first one is we want to make it affordable.
Yeah.
And the problem is, I've been to where they make the implants in Sydney, and it's an extraordinary process, and only 2 parts of the implant are machine made. All the rest is handmade.
That's
including wrapping 22 tiny hair-like wires around each other to put into the electrode array, which is only 0.6 of a millimeter in diameter. So it's highly technical, but the more that are made, the cheaper it'll get, and one hopes. Yeah. The second thing that's going to be very interesting is using the electrode array to put drugs into the inner ear, perhaps to try and stimulate growth of hair cells, or even to get stem cells to grow new hair cells. So that's a huge area of research, and the electrode array in some way may be useful for that as a means of access. Again, as I mentioned, better and more consistent outcomes is, I think, going to be one of the advantages in the future. Bilaterality and the hybrid. And then, of course, finally, a totally implantable cochlear implant. And so no external device, and you plug yourself into the national grid at night to recharge the battery.
That would be perfect, wouldn't it?
Well, it does exist.
Wow. That's
that's all in the future.
Well, I do like this last slide you've got, Bill. I'm going to have to share it because it is quite funny, and you can tell us a little bit about this final slide of yours, Bill, which I find quite funny. Just hold on till we get it up. It's I'll skip through these, but your last slide I did like it, and it made me this one.
This is a patient of mine whom I didn't know had a hearing dog until very successful implant. She loves it, uses it all the time. And anyway, on her last visit, she brought little Muffy in with her. And I couldn't resist taking this photograph because although she does, I asked her if she was going to put the dog down, and she gave me a very dirty look.
You're a shocker. Redundant, but still love, but yes.
I didn't know. She knew I was joking.
Oh, you're a shocker, Bill. It's but Bill, that's been very insightful. I'm just looking to see if there's any sort of questions up here that's come through quickly before we go. Let's see. We've got quite a few people just saying hello, and they're doing really well with their surgery. And so one's come through from Sonia. So she's asked, Bill, when a baby has severe profound loss in one ear, and given the diagnosis, is the child likely to lose hearing in their good ear as well? And can they be funded for an implant now rather than waiting until both ears are seriously affected?
That's an exit. There's several points to that question.
Yeah.
The first thing, of course, is why is there hearing loss in only one ear?
Yeah.
And just because there is a loss in one ear doesn't mean to say the other ear, if there's no congenital or anatomical problem, there's no reason to suppose the hearing will go off in the other ear.
Yeah.
So that would depend very much on the cause of the hearing loss. And the second thing is putting an implant into when you've got normal hearing in one ear and putting it into the other ear is certainly well accepted overseas. To be honest, because I'm not in the pediatric program, I'm not sure if it's funded by the government at the moment, but certainly single-sided implants with normal hearing in the other ear can be effective in helping children develop normal language and hearing and development.
And another question, so how many CI surgeons have we got in New Zealand now, Bill?
Sorry?
How many CI surgeons do we have in New Zealand at the moment?
Oh, okay, 2, 4, about 9.
9.
So we've got Christchurch, Wellington, Auckland.
Right, so it's...
And the reason still, it's interesting, although the surgery is relatively straightforward, like any operation, when things aren't going well, you need to have quite a lot of experience. So we don't want every ENT surgeon in the country doing them because there's just not enough to get good at them. So it does go back to limiting the number of surgeons just so that they get experienced in when something isn't quite right.
Yeah,
it's an easy operation when it's going well, but when it's not going well, it can become quite difficult, particularly with other anatomy such as the facial nerve, which we do go very close to.
Yeah, and I mean, that's why you need the expertise and be able to, you know, as you said, if you're only doing 1 or 2 surgeries a year, you're not going to develop the skills required. So that's why you need to be doing, you know, enough surgeries to get, you know, get the skills required, isn't it? So it's
yes, exactly.
And I think another couple of these questions, but I mean that we know, it's like there's about over 200, I think, on the waiting list at the moment. And the cost for a private patient is around 50,000, I think, because it's the device and the surgery and the follow-up cost. I think that's what we tend to say, isn't it?
Yes, that's about right. Yes, and that's over a period of several years, though. It's a maintenance thing as well.
Yeah. Well, look, Bill, we've gone over. I'm cognizant of people's time. They've been really good. It's been lovely to have everybody for us for the hour, Bill, for your time and putting this presentation together. We really do appreciate it. Everybody, we will give you a follow-up email tomorrow with the link to the actual surgical video if you want to view it, but bear in mind it has got graphic surgical content. For those that want to get a bit more of an in-depth view of a surgery, you can see it. And I'll also be uploading Bill's presentation, you know, to the Pindrot website on the webinar page for Bill, so you can check that out there. Bill, thank you so very much for your time. I've really enjoyed speaking to you this morning and for you giving us your time. It's been wonderful. It's a pleasure, and I love talking CI. And I can't thank you enough for your years of dedication to the CI program, Bill. You've you've changed the lives of many people, and and you're well admired for what you do, and it's been a pleasure.
Well, thank you. Good. Hope everybody enjoyed it. Yeah. Bye.
Thanks, Bill. Thanks, everyone. See you in the next one. Bye-bye.